So with that, it is my pleasure to introduce the Vice President of Health Policy Institute of Ohio, which is a nonprofit organization located in Columbus, Ohio. It was created by a group of health foundations with the vision that Ohio be a model of health, well-being, and economic vitality. And their goal is really to provide independent and nonpartisan analysis to create evidence-informed state health policies that improve health values. Hopefully, Amy, I've done justice to HPIO. Please feel free to add additional details to that, but I'll let you go ahead and share your screen and get started. Please join me in welcoming Amy Bush-Stevens.
Good morning, everyone. Happy Friday. I'm honored to be with you guys on your final session. It sounds like you have had a really in-depth look at these challenges, which is fantastic. And today we're going to be kind of zooming out and looking at the big picture and focusing on policy. But first, let me make sure I'm sharing, whoops, my slides. There we go. Are you guys seeing my first blue slide?
Yes, perfect.
Okay, wonderful. So just a little bit about myself before we jump into the content. I am a vice president at Health Policy Institute of Ohio. I have been there for almost 10 years now. It's a fantastic team that we have. We are a small organization, but we do focus on state level policy. So that's going to be my frame today. I am not a clinician. So I think probably many of the other presenters that you have had and many of you on the call today are clinicians. So this is really a different kind of look, more of a systems and policy look at these issues. And I am working from home today, and I am newly empty nested. So my daughter is starting her freshman year in college. She is off in Chicago. We miss her terribly, but it also means that I have a new room that I've been filling with plants. So that is where I am today, but I don't anticipate any interruptions. Nice and quiet here. And a little more info about our organization. This is our vision and mission, which has already been mentioned. So our primary audience is policymakers. So that means the members of our General Assembly and our state agencies, particularly our state agency leadership. And then, of course, all the other stakeholders that influence the policymaking process and local level partners as well. We are fortunate to have support from a variety of Ohio-based foundations that fund our work. We also do contracted projects, often with state agencies, but these are our core supporters that we always like to thank when we share our work. If you are not already familiar with our organization, I strongly encourage you to visit our website, and you can sign up to be on our mailing list so that you get our publications. We have a health policy news that comes out every Friday, just gives kind of a quick roundup of relevant news. You can sign up for that. And of course, if you're a Twitter person, please follow me on Twitter, follow us on Twitter, and maybe you can even tweet during this session today. Here's what I'm going to be covering today. The main thing we're going to focus on is a policy brief that we released last year, which is an addiction policy scorecard on children, youth, and families. And then we'll kind of zoom out a little bit further and look at another publication that we recently released on addiction, and then close with some information about that we've done on adverse childhood experiences and things that you can do to influence the policymaking process. So these are the 3 HPIO policy briefs that I'm going to be talking about today. There's a lot more detail in these reports. If you want to dig in and learn even more, I encourage you to check those out. And we produce a lot of policy briefs and reports at HPIO. So I'm sure there may be others that interest you as well. And we also host forums now, mostly online. Um, and sometimes they focus on child health. So hopefully you can join us for one of those in the future. Starting with just some kind of big picture data on the challenges that we face in terms of addiction and child welfare. The lighter blue line on the bottom is the number of drug overdose deaths in Ohio. This has continued to increase. I'll share a slide later that shows the 2020 data. So we did have a sharp increase in 2020, and we're hearing from local partners that that has continued in 2021. And then the line at the top is the number of children in Public Children Services Agency custody. So you can see there's been this relationship in those two trends, which I'm sure is not surprising to anyone on this call today. This is looking more specifically at removals from the home due to parental substance use. So it's about a third of removals that is the given reason, and you can see the trends there over time. And then this is with updated data. So it did go down quite a bit in 2020. Of course, there's COVID and the potential impact of COVID on the reporting of child maltreatment. This is the neonatal abstinence syndrome trend. And I think this group is probably very familiar with what NAS is. And you can see that based on the data that we have, which I'm not so sure surveillance is giving us the full picture, and we'll talk about that in a bit, but we have seen some improvement in this trend based on the data that we have. So hospitals are required to report this, but not necessarily to screen in a universal way. So that's a little bit of a challenge. Okay, so now we'll dig into the specifics of this report that we released about a year ago. So there have been some changes in the policy environment and the data since we released this report. So I'll try to kind of update things as we go, but feel free to drop things in the chat if you're aware of other new things that have been happening, because there is a lot happening in this space in terms of policy in Ohio, which is great. So this publication is part of our addiction evidence project. This is work we started back in 2017. We've addressed several different topics, and the fourth policy scorecard report in this series focuses on children, youth, and families. We have taken a comprehensive approach in this work, understanding that addiction is complex and involves many different sectors. So if we're going to look at it from a policy perspective, we need to take into consideration all of these things. So this is where the children, youth, and families focus fits in with all of that. Basically, what we've done with this project is we identify how Ohio can improve. So we're looking at what are our strengths, what are our gaps, what do we need to do to improve? And we get to those conclusions based on looking at what have we done. So we do these very detailed inventories of all the policy changes that have happened in Ohio in recent years. So legislation, rules, regulations, state agency programs. And we have literally Excel sheets with like specific information about policies. So if you want to dive really deep into some rabbit holes, you can find that Excel posted on our website. Then we also have evidence resource pages where we look at what does the evidence say is most effective for addressing these issues. And then we kind of put that information together. What does evidence say is effective? What have we done in Ohio? To what extent is the evidence-based stuff reaching lots of families and reaching counties across the state, and then put all that information together to say, this is where we're doing good, this is where we're not doing so good. And here's what we should think about. So this is the website where you can get all that kind of cascading levels of detail if you want more information. So there were 133 policy changes that we looked at specific to children, youth, and families. And so you can just kind of see the volume of attention that these issues have gotten from policymakers. So prenatal drug exposure and child protection have gotten sort of the most attention from policymakers over the past few. So this is 2013 to 2019 is what we were looking at. And then we kind of do a rating looking at to what extent are things matching the research evidence and what is the reach of things. So for example, family-focused prevention, we are doing some very evidence-based things in that area, but they are not reaching nearly enough families. And so that's why it gets rated as weak. Okay, so now I'm going to walk us through some of the key findings, and I do want to make sure I am staying on time. Okay. So these are 3 key takeaways from this report. These will not shock anyone on this call. So addiction's toll on families is far-reaching and requires a comprehensive response. We know that parental addiction can harm children in many different ways, and I know that's a lot of what you've been learning in this series. But Ohio has launched several initiatives to address this crisis. But we know that more can be done, right, to prevent trauma, to ameliorate trauma, to build resilience for families. We are at a hopeful moment for change. This issue has gotten a lot of attention from our policymakers in Ohio. There's also been federal policy changes. So things are happening. This is not an issue that's being ignored. And then the third thing here is that implementation and evaluation are critical next steps for where we are. So there are good things in motion. We are not always great at evaluating and data collection in Ohio, but we need to make sure that we are evaluating these changes to see if they're having the impact that we want to see. Okay, so here are some of the opportunities for improvement that I'm going to highlight. So the first is building on the current momentum to improve children's services and prevention, to ensure access to addiction treatment and recovery for parents, and to improve screening, data, and early intervention for prenatal drug exposure. So we'll start with the children's services and prevention area. This is a photo of early childhood home visiting, which is just one example of an effective prevention approach that has been prioritized in Ohio. Do we have any home visitors on the call today? Do you think, is that part of the group? Maybe.
Definitely early intervention.
Okay, great. So here are the strengths that we identified in this area. Looking at the policy changes. So strong policymaker focus, including leadership from the DeWine administration. So we have this really solid foundation set for evidence-based prevention, and several comprehensive programs are in place. So this is a picture, a timeline of all of the work that has been going on in recent years. This is focusing on state level. In the report, we also talk about some of the federal level changes as well. But you can see, particularly with the DeWine administration, there are several things that have been happening, including in 2020, there were some reports released that had recommendations based on stakeholder input. So if you want to learn more about what the DeWine administration has been prioritizing and is moving forward, I suggest checking out those reports that are listed in the bottom right. A minute to look at that. Oh, and here are covers from those reports. And this implementation plan, the Ohio Family First Prevention Services Act implementation roadmap, includes, there's a prevention plan that's part of that. So this is a federal law that was passed in 2018. It has several implications for Ohio Department of Job and Family Services, and also for how our local public children's service agencies do their work. And as many of you, I'm sure, are familiar, the purpose of this law was to keep children in the least restrictive, most family-like setting possible. So really trying to shift away from congregate care as much as possible, and towards more kinship care and prevention. Family First does place a strong focus on prevention of maltreatment and prevention of out-of-home placements, and it requires the states to develop prevention plans that take programs and services from a clearinghouse of evidence-based approaches. And so Ohio has, in the first phase, has chosen these specific programs and services. And you'll note that Healthy Families America and Parents as Teachers are also part of the Help Me Grow program. And the federal government will reimburse for 50% of the cost for these programs for kids who are in the child welfare system. One of the programs that's included is Ohio Start. This is a program that's already pretty widespread in Ohio. You can see the map on the left of the rollout of the cohorts of the Ohio Start program. This is led by children's services agencies, and it is focused on helping families with parental addiction. And then there's also the MOMS program, which is a little less widespread, and it is more led by the healthcare provider side, but also focused on parental addiction. So some good efforts happening across the state. Okay, now we'll look at gaps. Despite these strengths, we of course face gaps and challenges when it comes to prevention and children's services in Ohio. So as I'm sure folks are familiar, our local children's services are really stretched thin. We have inequities in our child welfare system. And we see this limited reach of the early childhood evidence-based prevention programs. So this is data from PCSAO, Public Children's Service Association of Ohio. The caseloads for PCSAs rose 33% from 2013 to 2020. And the local agencies are reporting increasingly complex needs of children in foster care, rising placement costs, and burnout among their staff, and sort of secondary trauma experienced by their caseworkers. So the tricky thing about where we are now is that we have these new, with the Family First Act, we have this new focus on prevention and some increased funding for prevention, which the plan is that over time we'll reduce these caseloads. However, the children's service agencies still need to focus on the current caseload, and that will be with us for some time. So there's a lot of opportunity there, but I think it is kind of a challenge for our local agencies to do both of those things at the same time. And then I want to highlight the inequities that we see in the system. So the dark blue here is the percent of Ohio children in the population overall, and then the lighter blue is percent of children removed from the home due to parental substance use. And you can see there is some disproportionateness, particularly for African American and multiracial children. And we see this throughout the child welfare system. You can look at other metrics as well and see some of this disproportionate impact. We also see disparities by geography and income. So this final gap we highlight here is that not enough families are currently reached by evidence-based prevention. So only a minority of families are reached by these really good programs that we have to prevent problems and to stabilize families. So only 17% were getting evidence-based, so the kind of home V, kind of gold standard home visiting models. And this is among eligible families. So this isn't all Ohio, this is like the income eligible. Head Start, 37%, and then 14% for state-funded early childhood education. So we have some really good programs and resources. They're just not reaching enough of our families. All right, so now we have some time to get into a discussion, and I would love to hear from everyone. And do you all do this discussion via, do you let people talk, or do you do it via chat?
That's a great question. A lot of times we'll do a little bit of both. Sometimes people feel comfortable unmuting, and some folks will put things in the chat. They're usually pretty good at taking turns.
Okay, great. Well, certainly if you have any questions about anything that I just covered, let me know. But I do have some discussion questions for you.
And Amy, there is one question in the chat. Sorry, I didn't want to.
Oh, okay.
But before you get into your discussion question, Michelle Raleigh Roberts was wondering, when does the kinship support program start kicking in? Now, and Michelle can come on off of mute and maybe clarify her question.
Yeah, there have been some changes made to kinship support to increase support for kinship families who have historically had less support than foster families. I actually am not familiar with the exact implementation timeline right now. Is there anyone else on the call who knows?
No, we usually have some folks from Children's Services on.
Yeah, I can tell you what it looks like in our county.
Okay.
Sure.
So if it's kinship and they receive temporary custody of the child, that's when it would start. Once they have the temporary custody paperwork. And that's for the kinship stabilization funds. So it'll last 3 to 4 months to stabilize the child or children into the home.
And Carly, what county are you in?
Union.
Okay, thanks.
Okay, well, I'll start with my first question, but if more questions come in, let me know. So what changes, from your perspective, from where you sit, what changes are most needed in the Children's Services system to better support families at risk for child maltreatment? So thinking of that prevention side.
I think it starts at the very basic with training. We, especially in our county, we have experienced where we're hiring and we hire somebody and 2 days in, they're so overwhelmed that they leave. We've had, I want to say, roughly 20 hires that within the first 3 days alone have started, shadowed a portion of our jobs and left their badge and phone at their desk and never returned.
Wow.
So I think we, at least our county, we throw a lot at you very quickly. And that's very overwhelming for somebody who maybe hasn't had any experience at all. So because we're trying to get them in and trained so we can get staff, but in doing that, it causes so much uncertainty with the new hire. Like, oh my gosh, this job is really hard. Can I do this? When realistically, if we would go slower, really take the time to say, okay, not all cases look like this. Not all court hearings go this way. Your day isn't always going to look like this. Like just the very basics when people start would at least keep them there longer. So we would have people who could stick around and really stay to help families, because when you hit a year at our agency, you're essentially a senior worker.
Do you feel like COVID has made it more challenging with staffing? Just as a follow-up.
In the connecting with your coworkers piece, yes. Because you're only seeing a snippet of people in the office. So the new hires, they come into the office, but not all of us are there. So they're kind of limited on what they get to shadow. But realistically, we're kind of lucky at our agency. We can come and go and work in the office whenever we want. We're assigned certain days, but we can come and go. So if we know there's a new hire, we've all tried to make an effort to be in the office at least the first couple weeks, so they have plenty to follow us around and do and ask questions. But it does make training hard too, because if we're not there to show them, because we're at home doing it, they're not learning it.
Mm-hmm.
That help. But I'm also hearing that peer support, right? And those social like support networks that come with, you know, preventing burnout and all of those pieces.
Yeah.
So it sounds like training and then potentially like burnout prevention for those that are the folks on the ground. I think those are really great points, Carly. Thank you.
Yeah, thank you, Carly. I think the other thing too is like she mentioned, like even backing it up even further. And what we've heard from some of the moms in recovery and another project that we're on is, and even the OBGYNs that support them in their high risk clinics, is that it could be any random day and you have no idea what is the protocol for a child to be removed. And so I think that in and of itself adds to that stress that you were just mentioning, Carly, of you're going to go home at night and own that. And that's just human. Like, you know, did I do the right thing for the child? Did I do the right thing for the family? And that contributes so much. And that's where a system gap is, in my perspective. If we had some more specific algorithms or protocols, if we had some better training around what this looks like, that, yeah, a child may test positive because the mom was in methadone treatment, but that doesn't mean the mom isn't doing what she should be doing. And we want to keep that mom and baby together. So I don't know, I would love to hear from other folks like Carly as well about that. But I think, you know, Amy mentioned the universal testing is not necessarily done across the state. What even those hospitals that are doing universal testing, NAS looks different. And I think that that's a concern too, in how they define NAS with treatment, NAS without medical treatment, you know, so I don't know. That's kind of where I feel like we could start, is getting some more protocols for those things to help out the Child Protective Services teams.
I think part of that too is knowing, so a lot of hospitals, you know, if mom has tested positive or baby has tested positive, even if they have like, you know, their prescription for Suboxone or something, the hospital typically lets them know like, hey, we have to make a report over to Children's Services. Explaining a little further that just a report doesn't mean we get involved. Like they have to make that report. It doesn't mean, there are so many other factors going into it than just the hospital calling. And that puts a lot of just scare tactic into new moms, and they're already in a very fragile state with new babies and maybe trying to continue their recovery, and they're going about it the right way with their Suboxone or whatever. But making it more clear that, hey, just because we're doing this does not mean they will be involved. So clarifying that a little bit when saying we have to make a report.
I think it's good to let women know really early on in pregnancy, if they're in any kind of treatment, about the CARA Act. Empower them, let them know this is how it goes. This is not, you're not being targeted. This is a way to try to help keep kids who may otherwise fall through the cracks, and let them know about it so they're empowered and more interested in getting together all the supports they need to be able to demonstrate their fitness as new parents.
All right, this is great experience that you all bring to this, in the interest of time, I'm going to jump us to question number 4, which is, what makes you feel hopeful about progress to reduce child maltreatment in Ohio? There's got to be some hope out there.
I mean, I would have to say, like, just with what you've showed us so far, it just goes to prove that there is someone that's out there that's researching this and implementing policies just to make a slight change. Like, even if it's as small as just in one county, or there's the policies that are available to kind of share across the state of Ohio, I feel like that, makes me hopeful that there is change coming. And I know with change there's always resistance. And so to implement that kind of stuff, but the more that we can reach out to people and educate people on what's available, I think that is the hope that, everything is going to eventually be available for everyone.
I think too, I was struck by a slide you showed, Amy, about the things that are available that aren't reaching families, like the early intervention and the Head Start and other things on that slide. And I think there've been a lot of projects at our institution in Cincinnati and other places in the state to try to connect families to those resources. I think another set of eyes on the family to help support and get things, hopefully stabilized quicker by having those kids involved in those programs is a helpful thing. And I think reaching those families has been something that's given me hope, trying to reach those families.
Okay, in the interest of time, I think we need to move on to the next section. Okay, I'm keeping my timer going. I know it's tricky. Okay, so the next area I'm going to focus on is treatment and recovery for parents. And we have some strengths here to highlight in Ohio. First being that pregnant women are identified as a priority population for publicly funded behavioral health services. There have been several Medicaid policies that have improved access, and some pending Medicaid policies as well. And I just want to emphasize the importance of Medicaid for this population of families that we're talking about. There's a really strong overlap here. So 90% of the newborns hospitalized for NAS in 2018, and this consistent proportion across years, were Medicaid enrollees. And then this is a big number here. In 2019, more than 14,000 female Medicaid enrollees were diagnosed with substance use disorder in the year before the birth of their child. So this just really highlights what a critical role Medicaid plays in addiction treatment coverage. And that just can't be overstated. And Medicaid does cover medication-assisted treatment and other effective treatment services for many, many families. Ohio has many reforms in the works that are designed to continue to improve access to care for families struggling with addiction. One of them is continuous postpartum coverage for 12 months. So this was actually in the state budget. So this is coming down the pike. So Ohio is joining some other states that have already done this, and absolutely critical for thinking about treatment access for moms with young children. So positive step here. Of course, we have gaps in this area. So we have few treatment providers that actually offer childcare services, particularly when we're looking at residential beds. We still have minimal access to medication-assisted treatment in some of our counties. We've certainly come a long way in that, but not every county, for example, has a methadone provider. And then we still have unmet need for wraparound services, particularly when we look at housing. I mean, all wraparound services and recovery supports, but housing is just so critical. So just kind of a look at some data. This is survey data of SUD treatment facilities in Ohio. So only 20% had programs specifically tailored. Only 9% offered childcare, and only 3% offered beds, so residential with beds for children. And then this is from a study of recovery housing that was done in the greater Cincinnati region. And so of 92 recovery houses in the area, only 10 accepted women with their children. And I suspect that this pattern is true in other parts of the state as well. So you couple this with our affordable housing crisis, and you can see how important a piece of the puzzle this is. Okay, the last area I want to highlight here is related to prenatal screening and early intervention. Okay, strengths in this area. Hospitals are required to report NAS. As I'm sure all of you are familiar, there was a policy change in 2019 that allows children under age 3 diagnosed with NAS or fetal alcohol spectrum disorders to be eligible for early intervention through DODD's Help Me Grow program. So that was a great change. And then we know there are lots of cross-system efforts happening. There are partnerships between ODJFS and the Department of Mental Health and Addiction Services, the Department of Health, who are working on this issue, and the Ohio Perinatal Quality Collaborative as well. The gaps in this area are really all about consistency and standardization and data. So we really don't have that kind of universal screening across the state for NAS, FASDS, and for SUD among pregnant women. And so we really have some data gaps, I think, in terms of our ability to do surveillance and evaluation. And then plans of safe care. We certainly have heard from folks that that process could be improved. So here's some data that we've been kind of puzzling over that I think kind of hints at the fact that our surveillance data is not great. It's hard to get a sense of the scope of this challenge. So the top bar is the number of women diagnosed with drug abuse or dependence, which is the language used in the Ohio Hospital Association reporting. So OHA reports to ODH. And so that's 4,999. This is 2018 data. And then the bottom number is the number of women covered by Medicaid diagnosed with SUD within a year before delivery. So these are not apples to apples numbers, because the top number is all payers. It's not just Medicaid, and it's at the time of delivery. So shorter time window. The bottom number is only Medicaid, and it has a year look back. But it just seems like these numbers should be more consistent. And so Medicaid is probably capturing reality, right? At least for the Medicaid enrolled population. So I think this is telling us that some women are falling through the cracks and may not be getting connected with care that they need, and that our surveillance is not great on this.
Amy, can I ask a clarifying question real quick? Sorry.
Yeah.
With the number up above, would that be a physician that codes, like in the electronic medical record, a diagnosis related to substance use disorder at the time of admit for delivery? Is that how that data is pulled?
I think so, but if there's anyone on the call who is actually like directly involved in that process could chime in, that would be great. Because I'm a little removed from the day-to-day.
And that's fine. I wasn't
reality,
sure, but I wondered if
yeah.
you might see, and I went in that, I think, so not to derail your talk, but so is that just sometimes they're just coding exactly what they're there for? Or is there a reluctance to put that code on because then they're worried to trigger children's services and it's
Right,
would be really interesting to
yeah.
think about and dig into
Yes.
that important piece.
Yes, I would love to know why this is so different. And we've asked Medicaid, we're still waiting for some clarity on that. But if folks on the call have ideas about what that looks like, and it could also just be inconsistency across different hospitals, different counties. I mean, it's kind of a mystery to me.
I know for our hospital, if you either admit to use or have a history of use, and then there's a drug test that follows that before you deliver, of course, and then of course for the baby. So I know that that's how we track it here at our hospital. So the ones that don't say anything about having a substance use disorder or being diagnosed with one or anything like that, then I feel like none of that action is taken unless there's like probable cause to think that something may have been going on that no one has caught up until that point.
Mm-hmm.
And depending on when she delivers and how closely or how recently she used, and depending on what substance she used, that baby might not test positive. And so that screen, that baseline, like, she kind of skirts under the system. Yeah, you're gonna, and if they're not linked up, right? Like you wouldn't know in a hospital that this person who's delivering a baby has Medicaid coverage and a substance use disorder. So there's no linking of that data unless she discloses it.
I'm Rhonda from Montgomery County, and I haven't worked in children's services in over 10 years, but when I worked there, a baby born in Montgomery County, they was testing everybody. If you were born with any addiction or any substance, they called children's services. So I had to go meet several parents at the hospital and make sure they had a plan before they brought them home, or we would put them in care. So we made sure they had a plan, but that was probably 10 years ago, but that was the process. So in all the hospitals, I went to all of them.
I'm a physician. We had a mother that said that she would go to prenatal care at a hospital that maybe would test the time of delivery. But then at the point of delivery, she would specifically select a hospital that didn't do testing upon delivery because she knew the consequences if she did test positive. And so I think that might be another place that we're missing that screening.
I think also, I mean, when I look at these numbers compared to what numbers we have just in the Children's Hospital data, when you include marijuana, we had about 8% of the deliveries, and then we covered 20,000 deliveries. So, this number doesn't really, I mean, if that's what we had just in the Cincinnati area, it's so I think that this probably, that doesn't get everybody, or it's just people that are newly diagnosed at the time of delivery.
Great, thanks for sharing, Mona. I think we could keep talking about this, but I'm gonna let you go ahead and go on, Amy, so we keep you on schedule.
Yeah, well, just I'm almost to questions, but just kind of, I think what this discussion highlights is that the challenge here is balancing, like we want to make sure that women with SUD are being connected to treatment and help. At the same time, we need to make sure we're not deterring women from seeking prenatal care because of fear of child protection, we also want to make sure we have good data. You know, we need good public health surveillance data so that we know what's going on. And so the policy challenge and the implementation challenge is to really balance those three things. And it's not clear to me that we have that balance just right at this point in time. So I see this as an area that could use some improvement. Okay, so just key takeaways from this report overall. And then we can get to our discussion questions here. But before I start asking my discussion questions, any other clarifying questions or just ideas from what I just covered? My first question is, what changes are needed to better support parents and family systems in treatment and recovery?
I mean, I'm going to say peer support because that's what I am, but but I see it to be a huge need. I know that like Ohio has come a really long way when it comes to peers and having access to them and placing them in different agencies and things like that. I know here, like we attempted to place one at CPS, but no one knew what she did and what she was there for. And so no one was referring anybody to her. So she just kind of was going and sitting there not doing anything. But I also think that that's a huge thing is to have, because if you think about someone who goes to treatment, so you go to residential treatment, you have like 16 people that focus on you and your recovery and what it looks like for you. And you have counselors and nurses and doctors and peer support and case management. And then you come home, say you don't have recovery housing to go to, and you come right back to the same situation that you left without hardly like 10% of that support. And so I feel like integrating something like that is something that's really needed to help people have a sustainable recovery when it comes to like aftercare.
And that's so important for the long haul, you know, because I think sometimes in this space, there tends to be a focus right on like pregnancy and delivery, but recovery is like, that is a long-term process. And so peer support is so important for that.
I think to piggyback on you, Joe, and that conversation around peer support, we just put in a contract with the state, and I think it's going to go through to start in January, where we're going to take some of our moms from the Empower Project, get them trained in the peer support model, and then create a module specifically for moms that want to be peer support specialists, so that we can do that for the long haul, at least like really focus in on that first year postpartum. So fingers crossed that will come in the next year or 18 months.
Great. Any other thoughts on how to help more parents with treatment and recovery?
Yeah, Kristen shared in the chat that she thinks residential treatment that can keep children and moms together would go a long way to support recovery.
Yep, and there are some of those models around the state, but not nearly enough.
I think possibly including education for the mothers as to what to expect from their children. I mean, particularly in the MAT treatment programs, to have discussions about NAS, discussion about long-term outcomes, so that the mothers are not feeling like they're terrible moms because their kids are crabby all the time, or terrible moms because their kids can't do this or that. They know how to get services.
Yeah, I think that's a really good point, Kathy. We've spent a lot of time talking about how when infants come home from the hospital, you know, they're incredibly challenging, and you have a mom who's stressed out and, you know, sleep deprived from just being a new mom, and also dealing with recovery, and at least knowing that's not something they're doing wrong would be a huge help and support for them. And knowing maybe some strategies on how to help the infant too, right?
My next question is about plans of safe care. So I'd love to hear from folks who are involved with plans of safe care on the call. So how can that process be improved?
I can say that Lucas County, we just received a community of support grant, and we've been actively engaging our leadership in developing a good system and a network of services for the 0 to 3 population, specifically babies that are exposed. And so I think that it's really important to bring that leadership together to make those decisions and to develop the services and identify the gaps that are within your county.
Are there others who are seeing maybe some improvements with how plans of safe care are being done?
Maybe Amy, can you, for some of us who may, and I'm not sure if maybe everyone does know about plans of safe care, but could you just summarize what they are when they're done for those who may not be aware?
Yeah, so it's a federal requirement, came out of one of those recent federal laws that babies who are born exposed need to have a plan of safe care that is led by the Public Children's Service Agency, and it's supposed to have some collaboration with other partners. But if someone who like directly works with them on a daily basis can kind of describe what that looks like, that would be awesome. Some of what we've just heard is that there's a need for stronger collaboration with the treatment providers because it's seen as a child protection thing.
That's what I was wondering. It seems like, you know, we've already talked about it a lot, like childcare and MAT treatment, early intervention. And that's why I was wondering with some of our early intervention folks, have you been involved in any of these plans of safe care?
I didn't, as a developmental specialist in Ohio, I didn't even know it was a requirement. So I'm really glad to learn that today.
So maybe some cross education into what they are, how they function. Oh, interesting. Sue is saying at last check, plans of safe care are not being initiated in our county by providers. This may be because it will trigger CPS involvement and prevent women from seeking care.
So again, that delicate balance of getting families connected, but not deterring getting help seeking. Yeah.
I wonder, Twinkle, have you and your Moms to Be program, have you had experience with moms with the plans of safe care? Have they shared those with you at all?
I have not. And this is interesting to hear from this perspective.
Yeah.
Yeah, well, it kind of gets to my next question, which is about collaboration. So what we've heard from folks is there's kind of, you know, there's the children's services folks, there's kind of the BH treatment world, and then there's the early childhood home visiting world, and kind of like early intervention, DD. And that those partners are not always well connected. And so what ideas, thoughts do you have, or where do you see this working well, where we have better integration and collaboration between those different sectors?
Just our personal experience, I feel like it's an ego problem. Like, and not to be rude, but like in our town, there's a few select MAC clinics. There's a few select outpatient mental health behavioral. There's a few select, like, you know, like CPS and ODJFS. And it's like, you can only go here for your MAC services, but you can't go here and get mental health. And so I think each facility or each agency has, like, you can come here because we provide substance abuse and mental health treatment. And we do match, so you can't seek services elsewhere, and have any type of outside service. So like we have integrated services that do like actually like community visits and home visits. They do mental health and have, you know, psychiatry and things like that. And like, you don't have to choose all of their services. Like, you can just be there for like their counseling, and you can go see a provider elsewhere. And I feel like we need some more of, you know, just kind of collaboration and things like that. I know just here where we are, it's like you're my patient, and we provide everything that you need, and you need to just stay here, and you can't seek services elsewhere. So
I think there's sometimes a sense that there is a secretiveness with Child Protective Services, that you don't always get information. There's sometimes a mistrust because it's different in different counties. So you don't really know what's going to work one place or another. And we even had a request for training for our navigator group when I was there, that's like, tell us what women need to do. Tell us how we can help them best avoid having their child taken away. And you know, we could not really get solid answers on that. So I think there's a mistrust of the system. There's a secretiveness from Children's Services. And I think until they are more open about their goals and putting out in the community how they can help and are willing to help women, because especially this group of women who often have a family past history of CPS involvement, do not trust this system and will not. And until that changes, providers aren't going to report, they aren't going to do plans of care, because you don't know what will happen once you do that. So I think that secretiveness needs to be resolved, and it needs to be a more consistent response and approach across counties in the same state, because you don't know what can of worms you're going to open when you do something. And I think that's many agencies have found that in the past, and that's what people are judging that on now.
I think too, like, sorry guys, I think just to piggyback off of what Sue's saying, you know, one of the things that I found to help break down those barriers is just building relationships with the case managers that I have, you know, kids on, you know, getting referred to me for testing, and they're in foster care. I make sure that I circle back around to those case managers and try to build a relationship and a rapport so that I can break down those barriers and ask those really crucial questions about, like, okay, help me understand how the logic is on this case. Like, how are we moving through this case plan? What are the things that are coming up? What are the barriers? And, you know, and that's the long, hard process if you're trying to do that with every case manager, you know, this is in every, you know, but I really think that that's an important piece of this. I don't know how to facilitate that maybe our public health folks can help us have some strategies around doing it on a more systematic level. But I think it is about building relationships with people.
In Hamilton County, with some of our programs, Children's Services have identified a particular team leader that works with the programs. But I think what also has to happen is that the maternal programs have to understand how important it is that children stay with their mothers in the mother's whole treatment scheme. Because I've also had some of the mothers therapists say, oh, this is too much for you to take care of your child and try to get into recovery yourself. So I think it's number one, there has to be this, everybody is really for keeping mom and child together, not just for the child, not just for the mom, but keeping mom and child together and working on that approach and finding out from the moms what they see is how this can work, not just telling them how it can work. So having, at least in certain treatment programs, having that concept that children's services is involved. But I mean, like one of the programs here in Cincinnati actually will be a safety plan for the moms so that the child can come with moms. So it's really working moms and children's programs together.
Kathy, there's some great, I know we're going to keep us on time. These are such awesome topics. There's some great conversations still going on in the chat. Steph has a question that would be great to have some folks weigh in on. So I think we can keep going in the chat, but for the sake of time, Amy still has a lot of other great info to share with us. Why don't we go ahead and let her move on?
Okay. All right, so now I'm just going to share some other work that we have done related to this topic. Recently, just within the past few months. So we released the final report for our Addiction Evidence Project in September. And the purpose of this new report is to just update on where we are in terms of trends, summarize our key strengths and gaps as a state, and then have a really prioritized set of recommendations. I mentioned earlier that I would say a little bit more about our overdose death trend. Ohio is the red line. Of course, we have been higher than the US rate for quite a while. And you can see that 2020 number has shot up. It was even higher than our 2017, which had been our peak. One of the main factors driving this is fentanyl in our illicit drug supply. Along the bottom, you can see the three waves of the overdose epidemic, highlighting which substances were most commonly present in overdoses over those three waves. This is looking more specifically at the different types of drugs. So obviously that fentanyl really driving things, but I'll also call your attention to the dark blue line, which is psychostimulants, including meth. And there is concern that we are seeing increases in that. And we are also seeing, there's also, of course, these are not mutually exclusive, right? So there is fentanyl in the cocaine, there is fentanyl in the meth. And we're seeing our African-American rates go up quite a bit. And often that is fentanyl in these other substances. So there is concern that we are headed for a fourth wave, which will be related to psychostimulants, which will have a kind of a different set of implications for families and children. Here are the strengths that we highlight in this report. So this is big picture. This is not just focusing on children, youth, and families, but we have seen in general a lot of interest among our policymakers. Kasich administration, DeWine administration. We do see many cross-sector partnerships happening at the state level and at the local level. We have seen improved access to addiction treatment over the past 10 years, as far as we can tell. Certainly been a lot of effort in that area. We've had a strong focus on overdose reversal. Obviously we need more, but there has been a lot of work done in that area. And then we do have some kind of specialized programs for families or for people involved in the criminal justice system and some of the family focused programs that we talked about. The gaps that we still face. So this is really looking at everything that we've kind of researched over the past 3 years. What really rises to the top? We asked our advisory group for this work. Given everything that we know, and we know so much at this point, right? We've been doing this for so long as a state. What really rises to the top as gaps that still need to be addressed? So we have uneven access to naloxone and other forms of harm reduction. So that includes syringe services and fentanyl test strips and other drug checking technologies. We, have done a lot of naloxone distribution. The overdose death trends tell us we need to do more. We need to make sure that that distribution is getting to grassroots groups. We need to make sure it's getting to communities of color, it's getting to rural communities, because we still have gaps. We are seeing an increasingly deadly drug supply. When we look at, when you really look at what's driving those increases, it's the nature of the drug supply. It's the fentanyl in everything. We still have criminal justice system policies and practices that hinder recovery and equity. We need to reform our criminal justice system in order to really make a change. We still have unmet needs for children at risk of trauma. All of you know. We still have inadequate behavioral health treatment and recovery system capacity. And our workforce is a particular challenge. So making sure we have all of the addiction treatment workforce that we need. And then data and evaluation. This is one that I always harp on. You would think that at this point in the overdose epidemic, we would have better data than what we have. And we really need to cultivate as a state more of a culture of evaluation. So we do lots of pilot projects. We don't always evaluate those pilot projects very well, and then share that information. So we need to be evaluating when we do these innovative approaches. We need to evaluate them. We need to share the results widely, so that everyone can learn from those findings. So here's what we identified, again, working with our multi-sector stakeholder group, to say, given where we are right now in the addiction crisis, what do we need to do? What are the recommendations? And there's so much, it's overwhelming, the number of things that need to happen, and we know about a lot of things that work. And so we kind of divided this up into what needs to happen immediately, what needs to happen kind of over the next 2 years, thinking in kind of legislative timeline, and then just long-term ongoing, what do we need to be focusing on? So for the immediate, here we're really talking about fentanyl, removing all barriers to overdose reversal, getting more of the fentanyl testing stuff out to people who use drugs, and then looking at how do we decrease the lethality of our drug supply, and kind of looking at what are we doing in terms of interdiction and law enforcement. Is it making it better, or is it making it worse? The second area is about reforming the criminal justice system, so reducing incarceration, removing barriers to housing and jobs for folks who have been involved in the criminal justice system. So this is those collateral sanctions. And then doing a better job of collecting and reporting criminal justice data. So of all the data that we look at for all the different topics, that's definitely the area where the data is the worst, especially like jail data. Local level data is not good. And then the third area is to continue to strengthen our prevention, treatment, and recovery continuum. So as we think about investing the opioid settlement dollars, really making sure that we're building a strong foundation, because these issues are going to be with us, right? Especially when we think about children, when we think about adverse childhood experiences, generational, kind of trauma. We need to be in this for the long haul. And so that's kind of where the child piece fits in. Increasing treatment capacity through telehealth. So there've been some really exciting opportunities because of the pandemic with expanding telehealth. So making sure we maintain those expansions that we've seen, and then continuing to build that behavioral health workforce. And then finally guaranteeing access to MAT, giving folks options for what MAT works best for them, and then making sure we have that recovery housing in place. So that's kind of the high level on that. And now I'm going to shift to another project, which is our Adverse Childhood Experiences Impact Project. And we also have a website for that on our page, and you can pull down a bunch more detail. I'm just going to go through it quickly because I thought this crowd would be particularly interested in this work, and it's been really exciting work. So the first policy brief was kind of descriptive, describing the prevalence of ACEs in Ohio, and then looking at what is the impact of ACEs on health outcomes, drawing that connection. And then the second brief is looking at the economic impact. So given the impact on healthcare spending, what does that mean for our spending as a state? And then the last one that we just released recently is looking at what works to prevent ACEs. And here I think there's been a lot of work done and progress being made around screening for ACEs and kind of mitigating ACEs or treatment for children with ACEs. We really wanted to put the focus on primary prevention. So what can we do to prevent those ACEs from happening in the first place? So as you know, things like witnessing domestic violence, having a parent who's incarcerated, a parent with mental illness, a parent with someone in the household with SUD. So that's really what we focus on in this publication. And so we take into consideration strategies that are primary prevention. We looked at the cost benefit analysis. So which approaches give us the biggest bang for our buck, which is always something our policymakers are interested in. And then which ones affect the ACEs that have the most significant health impacts, which we highlight in that second brief. So these are the 12 key strategies that we identify based on that analysis. The little orange circle are ones where there's evidence that they can reduce disparities based on race, ethnicity, and income. Of course, any of these approaches could help reduce disparities if they were implemented well. So we have things that I'm sure are near and dear to many folks on this call: early childhood education, early childhood home visiting, medical legal partnerships, which are where attorneys can help families kind of connected and referred through healthcare providers, help families address any criminal justice issues they might have, or deal with, landlords and things like that. Family income supports. So obviously now we have the child tax credit, but things like the earned income tax credit. Community-based violence prevention, school-based violence prevention, parent and caregiver and family skills training. So y'all might be familiar with Triple P or programs like that. And then school-based social and emotional instruction, mentoring programs for delinquency prevention, drug courts, which didn't really get into drug courts much today, but we have also family treatment courts in Ohio. Some of you might be familiar with trauma-informed care and behavioral health treatment. So we really lift those up to policymakers to say, you want to have an impact on preventing ACEs and you want to do it in a cost-effective way. These are good ones to focus on. And of course, we're doing all these things, right? It's just, are we reaching enough families with these approaches? We can't just do itty bitty, implementation here and there. We need to implement these things in a widespread way if we really want to move the needle on ACEs prevention. And then lastly, I just want to talk about what all of you can do, sort of thinking about the policy and system change and advocacy that you can be doing. So the first thing you can do is just disseminate the kind of information that I shared with you today. Check out these reports on our website, share them with your contacts. And then take a look at some of the specific opportunities for improvement and recommendations that are in these reports, and think about what you can do to bring these recommendations to the attention of decision makers. Maybe that's decision makers at your local government level. Maybe that's your representatives and senators in the Ohio General Assembly. And then to partner. So as we've talked about in the discussion today, continuing to build those bridges. We can't have, you know, just the addiction treatment people are over here and the children's services people are over here and the home visiting people are over here. And the housing providers are over here. From a family perspective, we need to have stronger connections between those partners. And I just want to emphasize to all of you that you have such a unique role and voice in the policy discussion. So we at HPIO, we specialize in data. So, you know, I can talk about data all day long. But it's really when we pair data with stories of real families and real experiences that we really capture people's attention. And so kind of the voice of families and having those stories is something that we're not really good at HPIO. We're working on improving doing that. But all of you, I know, have stories from your experience of working with families. It can be things like sharing kind of vignettes, examples of things families are facing, direct quotes, including families in kind of thinking about what you're going to advocate for and in terms of policy priorities, engaging them in that process. And so you can take our data and our kind of recommendations and graphics and all that stuff, and then add the story and the family voice to that. And that will be what gets the attention of policymakers so that we can keep making improvements. And I just want to encourage you too, that policymakers are, you know, they're just regular people, especially if you think about your representatives and senators. If you can meet with them when they're at home in their district, if you can show them the work that you're doing, it will make it real for them. If they, you know, if you can have your state rep come and visit your agency and show them what you do, they will remember that. They will remember that much better than me giving them a fact sheet. Even better yet, show them what you guys do and then give them a fact sheet from HPIO. But you guys have a very powerful voice in advocacy. So I hope you use it. All right, we have a few more discussion questions, 10 more minutes. Before I ask my questions, any more questions for me about any of that content I just went over?
Amy, for me, I put in the chat box a little bit ago, SB 216, I think it is. I don't know if you're familiar with that or.
Remind me which one it is.
It's the one that basically would be incredibly punitive and separate families.
Oh, right.
And so, I don't know, I just looked up the folks that are in the General Assembly. It looks like some Delaware County, Lake County, and the county outside of Cleveland. So I don't know, just similar what you were just saying, call to action, like we'll send that out with the follow-up to this session, but it would just be incredibly detrimental to families because it would set a finite time period that a mom or a dad would be separated from the child. And that I think is just so misguided on the part of the legislators. And again, like you said, they're human and we just need to educate them that how incredibly harmful that could be to the child and the long-term trauma that they would have. And it's not preventing ACEs. And I think it goes against everything else that you presented in that section.
Yeah. And is it Pavliga? Is it?
It's
sponsor.
Cyrano, Brenner, and Yuko.
Okay.
or I'm sorry, Senator Johnson is the primary, and then co-sponsors are Cyrano, Brenner, and Yuko.
Okay, so a really good approach would be to focus on the sponsors of the legislation and to meet with them in person, and to, you know, on the upside, they're concerned about child maltreatment. That's something that we all share, right? We're all concerned about child maltreatment. So you can kind of start at that place of, we have the same goals. Let me tell you what it looks like on the ground, right? Because they don't know what it looks like on the ground, or they maybe heard one story from one constituent one time. And they, you know, sometimes it's like they just don't have a lot of tools in their toolbox and not enough creativity. And so they see a problem and the only thing they can think of is to be punitive. And so helping them kind of see the broader range of things that we can do to address child maltreatment, I think would be really helpful. And there's always hope that there could be some amendments, some changes to the legislation. You know, maybe it could be turned into something good. So kind of starting from that place of not adversarial, but we have the same goal. And let me tell you about this family, and let me tell you about what this would look like for who we work with.
Amy, I have a question. When you said that data isn't shared, so Ohio University just finished up a 3.5-year Ohio Department of Health grant, where data was just in abundance, beautifully written reports about rural Ohio and taking care of high-risk pregnant women. And I guess my question is, does Ohio Department of Health share any of their data that they've received from all the grants in all the areas in Ohio with HPIO?
So they certainly, you know, will post some things. Sometimes there's also the new Data Ohio website, which is like a portal for agencies to post data, and there's some stuff on there. But what we really lack is just a systemic understanding that whenever you do an evaluation, or whenever you collect data from people, you have a duty to share that back out. Not, you know, obviously I'm just talking about aggregated data that doesn't have any individual identifiers. But I think there's an ethical duty that if you collect data from people, you need to share back what you found. And that we need to have a mindset of continuous quality improvement in our state government that says, we're always evaluating what we do. We're going to share those findings widely so that others can also learn. And we don't do that in a systematic, consistent way. And I think that's definitely something that we could improve across our agencies.
Thank you so much. Great discussion. I'm looking at the time. We have 4 minutes left. So I'm not sure we're going to have a chance to dig into the last few discussion questions, Amy, just because I want to make sure we've got time to wrap up. I don't know, any final closing thoughts from you, Amy, just in kind of through the discussion and those pieces?
No, this has been great for me. This time has actually flown by. I was a little daunted by talking for an hour and a half, but because from where I sit, I'm not doing the work on the ground. And so it's been really great to hear from all of you. And I hope this broader policy level look has been interesting and sort of a good capstone to everything that you have been learning over the course of these sessions. And just look forward to hopefully getting you engaged in HPIO's work going forward. We often have advisory groups for our projects, so sign up for our mailing list.
Thank you to all of you. I think this is as great as it is because not only do you guys show up, but you participate every time, and we learn so much from all of you. So I get all sad in the last time, but appreciate all of you. Continue the work you're doing. Look for our newsletter. Feel free to share that newsletter with other people at your agency as well. We are happy to do that. Okay, well, thank you so much, everyone.